to talk about kind of evaluating a headache in the emergency department. It's a very, very common complaint that people come in for treatment with. And there's, many different types, different kind of levels of severity. And sometimes it can be challenging to, make those diagnoses. But there's definitely, many of the different types of headache can be potentially very dangerous. It's certainly good to talk about some of the kind of more specific details there. But for now, at least, let's talk about our kind of review questions, and we can discuss those just to get started. So let me see. Here we go. And can everybody see my slides? Can see the questions?
Yeah, we can see it. Yeah, we can see it.
Perfect. Okay. So I chose many of these questions and kind of change things around a little bit so that we can hopefully have a discussion about some of the details here. But just to start, for the first question, we have a 20-year-old woman that presents with a severe headache that began about 10 hours ago. Has never had a headache as severe as this in the past. It started and became maximal in intensity within about 30 minutes. She's complaining of associated photophobia and nausea. In terms of the kind of initial diagnosis and management, what is the best initial choice here?
In our department, we used to take the patient for CT first. After that, if the patient have any problem in his in her CT, we take CTAs immediately, because I think the same stroke in this situation. Yeah, we need to transfer the patient to CTs immediately. Yeah.
Perfect. Excellent.
We choose D, letter D.
Perfect. All right, I agree. So in this, in this case, the kind of condition that we're, I would say, the most concerning possible condition here, and the way that this is presented is to kind of make you think of a subarachnoid hemorrhage. So severe, worst headache of life, beginning maximal kind of at onset, and with associated nausea, photophobia. There are other things that can cause a similar headache, but at least initially the thought has to go to the most concerning possible diagnosis. So, if we're thinking about this headache being caused by a subarachnoid hemorrhage, the test of choice initially is a non-contrasted CT of the head to evaluate for blood in the subarachnoid space. Depending on the literature, depending on your department characteristics, the patient characteristics that you see, anywhere in the 1 to 5% of patients presenting with headache may have a subarachnoid hemorrhage. So it's not especially common, but it's also not uncommon. So it has to be, pretty high on your list of high on your differential diagnosis. Most commonly, subarachnoid hemorrhage is caused by arterial aneurysms. There are some that can be caused by, obviously, from trauma, and there are other vascular disorders that can cause subarachnoid hemorrhage. But certainly the most concerning and the most problematic in terms of future management and prognosis are going to be related to intracranial arterial aneurysms. So within the first 6 hours, a non-contrasted head CT is highly sensitive to make the diagnosis of subarachnoid hemorrhage. About 98% or more will be positive and be diagnosed on a non-contrasted head CT. And that data is using information from CT scanners, at least in the United States, from older generation CT scanners from 20 or more years ago. And the new CT scanners are much more sensitive even than old scanners. So within the first 6 hours, with a negative head CT, for a clinically significant subarachnoid hemorrhage, the likelihood of missing the diagnosis is very low. But that's only for the first, six or so hours, traditionally speaking. In time frames that are longer than that, they have been having a headache for 10 hours, as in this case, or 12 hours or 24 hours, the sensitivity goes down significantly. Like I said, especially from a traditionally speaking, the next step in terms of diagnosis would be evaluating for the likelihood that they could have had a subarachnoid hemorrhage, which is looking for aneurysms. CTA is highly sensitive to evaluate for aneurysms as well. So I would say many departments and many emergency physicians now are using a very similar approach to UMC, where the first test is a non-contrasted head CT that can then be followed by a CTA if the non-contrasted head is negative. And then the likelihood of missing a subarachnoid hemorrhage or a clinically significant aneurysmal bleed is less than 1%. So you can say very confidently that the likelihood of missing a subarachnoid hemorrhage in these cases is very low. Good to see you. The next, the other choices here, I would say are, can we mute our mics? I'm just getting some feedback. Thank you. But the other choices here are kind of trying to distract you from making a definitive diagnosis. So the non-contrasted head CT in 10 hours out is debatably not appropriate because the sensitivity is not high enough to more definitively rule out the diagnosis. Obviously, you wouldn't want to treat somebody for their headache with an NSAID if you're concerned about a subarachnoid. And then an MRI, while relatively sensitive for bleeding in the subacute time frame, is in 12 to 48 hours, is pretty high. In the test of choice is still CT and CTA. Okay. Next question. So we, in this case, we have a 35-year-old woman that's coming in with a headache, saying that it's been progressively worsening over the last week. It's generalized. She has nausea, vomiting, photophobia. She is otherwise healthy, but was pregnant and had a uncomplicated vaginal delivery about 2 weeks ago. Physical exam is largely unremarkable. She does have some papilledema that you note on her retinal exam, and she has a CT scan shown here. Of the following, which is the most likely cause of the patient's symptoms?
I think it's AD, sinus thrombosis, because in the CT we can see the delta sign on the ventral veins in the brain, and she has a hyper state of coagulation because she is in a postpartum.
Perfect. Yeah, that's exactly right. That's exactly right. So, you know, this is kind of looking, kind of trying to evaluate for the very, I would say, significantly more rare condition than a subarachnoid hemorrhage or some of the other headache etiologies that we'll discuss here. But it's a sinus venous thrombosis. It is very uncommon and occurs very, very rarely, except in the post, kind of in a pregnancy and kind of shortly postpartum, and it's related to predominantly hypercoagulability related to that. Other hypercoagulable states can cause this as well, and there are can be associated with trauma as well, with skull fractures can cause this. Otherwise, the diagnosis is very challenging because the headache generally very benign initially. They rarely present with severe symptoms. It's commonly a headache that's kind of slowly been getting worse with some associated symptoms that you would expect with increased intracranial pressure, so nausea, photophobia, some vision changes. But kind of as time goes on, their symptoms become increasingly severe, and they may actually develop venous congestion, which can lead to ischemic brain injury and ischemic stroke. Otherwise, the test of choice for this and for this diagnosis is often CT or MR venography, and a kind of non-contrasted CT and even a non-contrasted and non-vascular MRI is insufficient to make the diagnosis. So in those cases with a patient that's had a progressively worsening headache, that's been seen in the emergency department, 1 or 2 times in the last week, should certainly raise your suspicion for this disease. And then the treatment is anticoagulation, if possible. Okay, next question. So we have, in this case, we have an 18-year-old, a healthy patient, generally healthy patient, coming in with neck stiffness and a headache. Began abruptly about 6 hours ago. On exam, he's has a very high fever of about 40 Celsius. He has a stiff neck and papilledema on exam. Of the choices here, what is the best initial management option?
In this situation?
In this case, we choose a non-contract, the CT scan first, because he comes to emergency because with after his dormitories and get the neck stiffness. Maybe he had the subarachnoid hemorrhage.
Yeah.
Good. I think that is very reasonable, and I think that this question it can be the kind of result, I guess, the answers can leave some ambiguity, or it can be somewhat confusing to of the choices, and there's certainly some practice variation. The choice that I was hoping that I was leaning towards, and kind of our general approach here is in the case of patients that present that you have a very high suspicion for bacterial meningitis, that empiric treatment should not be delayed to obtain definitive imaging, or to delay the workup. If your suspicion is high enough for their presentation and for bacterial meningitis in specifically. So, starting IV steroids and IV antibiotics to treat the bacteria, kind of being first priority. Second priority, I agree, would be, very high priority item would be getting a contrast CT of the head to evaluate for possible, for evidence of increased intracranial pressure. And then likely following that with getting a lumbar puncture. But the treatment, the definitive treatment, can often be delayed, trying to get the diagnostic studies done. And because there's such a high morbidity and mortality associated with delayed treatment, that in these cases that starting it early while you continue the evaluation would be reasonable. But I could certainly say that if they were able to go from the door, from the door of the emergency department straight to the CT scanner, that I think that would be a totally reasonable approach as well. And I don't think that anybody would fault you for that unless there was a significant delay in their care related to trying to obtain the imaging first. Does that make sense? I mean, I certainly think that people can have a difference of opinion here.
Because in this situation, our department thinks the patient have the same stroke, so we usually transfer the patient immediately to imaging department to take CT scan. After that, we have evaluates more exactly, and I and Dr. Weiss didn't change the temperature for the patient. We think 1 or 3 is 37 degrees Celsius. So we increase high temperature. So we take CT scan first. And I totally agree anything with you in this situation. Yeah. Thank you.
Yeah, I apologize for that. I'll try and be more careful using the right units using the right temperature units in the future. Okay, next question. We have here a 70-year-old woman presenting with worsening vision changes in her right eye and a severe headache that began several hours ago. No history of trauma. She has a visual acuity of 20/30 on the left and 20/200 on the right. She can move her eyes freely. There's no facial asymmetry. As you check the pressure, her eye pressure, on the left, it is 18, and then it is 65 on the right. Of the choices here, what is the most appropriate to begin initially?
I think this is to see. In our department, we usually ask for the specialist test for her eye before we treatment. But in this case, the old woman have a very severe headache and chest her visual acuity and elevated in her eye pressure. I think he gets glaucoma.
Yeah, exactly, exactly. The so this patient, we have, you know, even beginning her chief complaint is very concerning for acute angle closure glaucoma, and then our testing kind of confirms that diagnosis. So she has a severely elevated intraocular pressure on the right. And the initial treatment for this is acutely lowering the intraocular pressure, which is an alpha agonist, a beta blocker, acetazolamide, and topical pilocarpine drops to acutely lower the intraocular pressure. Occasionally, especially severe cases, mannitol or hypertonic saline may be used to acutely reduce the pressure as well, although that's relatively rare. If unable to lower the intraocular pressure to an acceptable level, that's generally thought to be about 30 to 35, then emergent ophthalmologic surgery is necessary to prevent total vision loss permanently in those eyes. But this is, you know, is certainly, you know, is easily treatable in the emergency department, and is something that can make a very big difference in terms of the initial diagnosis and based on the timing. Okay, I think this is the final question. So we have a 32-year-old that comes in with a headache, nausea, and malaise. It was there when he woke up in the morning. He felt well yesterday. There's a couple of other people that came in with him complaining of similar symptoms. The patient is afebrile with a heart rate of 102, normal blood pressure, normal respiratory rate. His oxygen saturation on pulse ox is 98%. He's slightly confused on questioning, but has an otherwise normal exam. Since coming into the emergency department, his headache has improved slightly. Of these options, what is the next kind of best step in management?
I'm so confused in this question, because maybe we check carboxy hemoglobin level, we need to play in a high flow incident, because maybe he gets CO poisoning, because he gets headache symptom and have two persons in this department have the same symptom, and this poison sometimes happen when patient in living in the department, because the air conditioning sometimes get this problem. Because in Vietnam, we not too much person live in a department like US. We don't have the same problem, but I just read some case in the textbook talk about that, the CO poisoning.
Yeah. So I was when I was kind of developing and working on this question, I thought that may be the case. That carbon monoxide poisoning, I'm sure, is much more rare in Vietnam than it is in the U.S., especially some of the colder states. So this is a patient where the most likely diagnosis, or the one of the main diagnoses of concern, would be carbon monoxide poisoning. kind of multiple patients from the same household with the same symptoms, the confusion, and kind of the abrupt onset is relatively characteristic. So when you have somebody that your suspicion is high for carbon monoxide poisoning or carbon monoxide exposure, the most important initial treatment is to start them on a non-rebreather high flow oxygen, because the rapidity that they can develop permanent deficits from persistent elevated carbon monoxide levels is very high. And the sooner that they are started on high flow oxygen, the better. Again, kind of similarly, and this is the textbook answer. I think the reality would be that you would be putting the patient on the non-rebreather while simultaneously checking for carbon monoxide poisoning, because there aren't very many scenarios that putting them on a non-rebreather would be dangerous. Then you would certainly want to be checking their carbon monoxide or carboxyhemoglobin level. I would suspect that there may be some carbon monoxide cases in Vietnam with people with suicide attempts, keeping a car on in the garage or in a closed space, or in people that are working in the kitchens, working in a kitchen that's enclosed. I could see scenarios where that may occur, but I significantly less often than in the US when it's cold and people have a furnace, heat being utilized in the home. So maybe up in North Vietnam in the mountains in the winter, they may run into this problem a little bit more often. But I doubt that there are many people running the heater in their home in Ho Chi Minh. All right, excellent. Thank you for that. Thank you for participating. That was great. I love it when we can have a good discussion about this. Okay. So we have, so now I have some of my lecture. Can everybody see this now as well? Or are we, let me see if I can change this one real quick. There we go. Can we see the PowerPoint now? Perfect. Okay, yeah. Good. So I wanted to kind of continue on our discussion about headaches in the emergency department. Mainly the ones that are life-threatening. Nobody really cares about people that come in and have a tension headache. Even migraines, are not dangerous, although they can certainly be very unpleasant. But the main things are having a high suspicion for more problematic headaches when you see them in the ED. So here's a kind of some more cases similar. We won't have to belabor these too much because we talked about many of the similar cases in the questions. So in this case, a headache in a 5-year-old female had a severe headache, maximal onset, was complaining about it to her husband, and after about an hour or so, her husband found her unresponsive, confused in the bathroom. When they get to the ED, she remains confused. Her vital signs are significant for a severely elevated blood pressure of 190/100. She's somnolent, but doesn't have any focal deficits on her neurologic exam. But this is the image that we get, that we have seen, that we get on the non-contrasted scan. Since our suspicion would be very high in this case, I think, for subarachnoid hemorrhage. So very clear, subarachnoid bleeding in the cisterns and in the fissures, that would be very concerning for an aneurysmal subarachnoid hemorrhage. So at least in the US, subarachnoid hemorrhage occurs, relatively common amongst people that come into the emergency department for headaches. But the absolute number is relatively low. By far, the most common causes are aneurysmal bleeding. More rarely, they're caused by arteriovenous malformations. And then there's a number of them that are caused by mesencephalic or different types of subarachnoids that are significantly more rare, both more rare and less dangerous in the long term. They're generally more common in women. They often happen in a younger population before the age of 50. And then most often you'll see patients that present with a severe, with subarachnoids in the 40 to 60-year-old age range. So certainly in that population, having the highest index of suspicion is warranted. Other risk factors for subarachnoid: smoking, hypertension, especially uncontrolled hypertension, alcohol use, patients that use cocaine, methamphetamines, even prescription amphetamines have a increased likelihood. And then any activity that involves Valsalva maneuver, which is a very, very broad range of activities, lifting weights would be one that comes to mind very obviously. But even straining to have a bowel movement is associated with subarachnoid hemorrhage as well. Generally speaking, in a spontaneous subarachnoid, these have a very high mortality. Many patients die before they arrive to the emergency department. And then in the patients, many of the patients that do, about 25 to 50% of patients with subarachnoid die. Of the remainder, a large amount have significant deficits, and they, it causes a significant amount of morbidity. The most kind of important prognostic factor is their level of consciousness during the initial evaluation. So if the patient is completely obtunded, comatose during the initial evaluation, their prognosis is extremely poor. But if they come in and have no deficits, they're just complaining of a severe headache, the prognosis in those cases is significantly better. And this is kind of a grading scale in terms of the initial severity of subarachnoid hemorrhage that can help with prognostication. I don't think that it makes a significant difference in terms of treatment or evaluation, but certainly in terms of prognosis, it has a huge impact there. So often these patients will come in complaining of the worst headache of their life. It's traditionally said maximal, maximal at onset, but what that means is that the maximum intensity occurs within the first hour of developing a headache. So it does not have to necessarily be 100% the worst within 5 seconds of the headache. It can be 30 minutes or even 45 minutes into the headache would still be considered, a thunderclap headache. Often they'll have some meningismal symptoms, nauseated vomiting. Sometimes they can have focal deficits depending on the location of the subarachnoid. And then if they have a especially severe aneurysmal bleed, they can have a third nerve palsy as well. And then there's a significant proportion of patients that will describe another recent severe headache, oftentimes that will have resolved spontaneously at home before their presentation. That's called a sentinel headache or a sentinel bleed. Sometimes these can be very challenging to diagnose initially, especially if their headache has started to resolve in that sentinel headache event. But it is important to evaluate for these folks because they can have rapid recurrent bleeding that can delay their care. So in terms of the misdiagnosis and the timing of diagnosis and diagnostic accuracy, modern CT scanners, that is, CT scanners that have been developed, within the last 10 or even 15 years, are extremely sensitive to detect bleeding in the subarachnoid space. Even within the first 24 hours, most CT scanners will detect clinically significant bleeding. So, if you don't have CT angiogram readily available, unrested CT scan is still likely to provide the correct diagnosis. But MRI is not necessarily the test of choice. It can often will misdiagnose small aneurysms as well, and is not a definitive imaging technique, especially given the time frame. If a lumbar puncture is utilized to evaluate for subarachnoid hemorrhage, as has been traditionally taught, xanthochromia, or the yellow appearing CSF, can take 12 hours to develop. So there's a large period of time in that 6 to 12 hour range where you may have a negative CT scan as well as a negative lumbar puncture. And if the suspicion is high enough, either repeating the lumbar puncture or obtaining vessel imaging would be the recommendation there. And this is talking about CT angiogram. There's been many studies that have looked at the evaluation for CT angiogram in terms of evaluating for for subarachnoid hemorrhage. The modeling that's been utilized has shown that the likelihood of a subarachnoid hemorrhage being missed by both CT as well as CT angiogram, that is lack of aneurysms on CTA but still having bleeding, is extremely low. A negative CTA effectively rules out the diagnosis of a life-threatening subarachnoid hemorrhage. So if both of those tests are negative, those patients could reasonably be safely discharged if no other underlying etiology is found in their workup. Cerebral angiography, that's invasive angiography, is part of the kind of diagnostic algorithm performed by neuroradiologists or neurosurgeons. Most of the underlying diagnosis occurs there due to related to their treatment, so coiling the aneurysm, and there's a significant risk involved in this procedure and has a relatively high complication rate. Of the non-aneurysmal, non-AVM bleeding, the perimesencephalic subarachnoids are much less concerning. They are often associated with venous bleeding and do not carry the same long-term risk of rebleeding or morbidity that aneurysmal arterial bleeding does. So in a patient that you see has blood that's limited into the perimesencephalic or prepontine cisterns, that is kind of in these areas. The risk there is very low. From the areas that are likely to cause aneurysms and aneurysmal bleeding, the circle of Willis is by far the most common area, and that is most commonly at the junctures between the internal carotid and posterior communicating artery, the anterior communicating arteries, and then the basilar apex, kind of forming the circle of Willis here, are by far the most common areas. The middle cerebral artery, kind of located more laterally and deep, can occasionally result in bleeding as well. And then the remainder are just far less common. So treating ruptured aneurysm, earlier treatment is better. So getting the neurointerventionalists or neurosurgeons on board early is extremely important. Reduces their risk of rebleeding in the future, and ideally improves their morbidity. Once they've reached the hospital and reached the treatment stage and coiling stage, their mortality does not actually benefit, though. I feel like this is, generally speaking, kind of outside of the realm of our practice, but whether it is done by an endovascular or exterior approach, certainly many factors go into that with the neurosurgeons and interventionalists. That is very well, I don't know if it's actually complicated or not, but they make it seem that way. And in any case, can be coiled or clipped. The complications that can occur following subarachnoid vasospasm, causing stroke-like symptoms and can actually cause ischemic stroke, is very high. Rebleeding, impaired CSF flow resulting in hydrocephalus and increased intracranial pressure, and subsequent herniation are the most concerning. More longer term, in the days to weeks following a severe bleed, fluid and electrolyte disturbances and development of seizures is also problematic. And then for pretty unclear reasons, severe intracranial hemorrhage and ischemic stroke may result in cardiac arrhythmias and ischemia due to vasospasm as well. The biggest concern, generally speaking, is rebleeding, which is why early diagnosis is so important, and it occurs in about 15 to 20% of the time. Trying to keep the patients in bed, blood pressure under control, ideally with a systolic pressure less than 140, and then early intervention to prevent rebleeding. Kind of following up with the neurosurgeons and interventionalists regarding incidentally discovered aneurysms is warranted, just because of the likelihood of subsequent rupture is relatively high, and in patients that have a significantly large aneurysm, the life expectancy in these patients is significantly shortened. Okay, so for our next case, We have a 25-year-old female that was recently pregnant, that had came in with some nausea, vomiting, and headache. Over the course of a couple of days, kind of was seen multiple times in the emergency department. And then finally, after about a week, husband found her confused, lethargic, and largely unresponsive. And on her exam, she's found to have significant right-sided deficits. In this case, kind of similar to the other case that we had discussed earlier, the concern in a postpartum woman with a progressively worsening headache and neurologic deficits is for cerebral venous thrombosis. It's a rare and challenging diagnosis to make. There are many different sinuses that can be clotted in the in and around the brain. Generally speaking, we consider the transverse sinus, this sagittal sinus, to be I would say the most common, but there are many different venous structures that can clot, that can cause significant symptoms. So, like I said before, it's really quite rare. It's much more common comparatively in the young, in children. It's more common in women, and significantly more common in adult women. And of the patients that develop strokes related to this, almost a huge proportion of them are related immediately to either pregnancy or in the immediate postpartum period. These can, the symptoms and the kind of development is caused by venous obstruction, eventually leading to infarction related to increased venous pressure. And in severe cases, it can result in severe intracranial hemorrhage that can cause herniation. Most patients that develop this have multiple risk factors. So oftentimes they'll have a thrombophilia. Most often they'll have oral contraceptives. And then of the others, pregnancy, inflammatory conditions significantly increase the risk. There's some other significant risk factors associated with particular oral contraceptive pills. The most common presenting complaint in these cases is headaches. Often will start relatively mild and then progressively worsen. As it does worsen, they will often start to develop kind of focal neurologic deficits related to localized increased venous pressure and ischemic symptoms. Oftentimes these patients will present with seizures as well. If they've progressed to the point of herniation, that's an extremely late finding and has a very poor prognosis. In these cases, the diagnosis, like I said before, can be very challenging. But keeping a high degree of suspicion in patients that are postpartum and have other risk factors, that is thrombophilias, contraceptive use is very important. These are empty delta sign, sinus, and then subsequent ischemia and vascular congestion. And the treatment for this is anticoagulation, if at all possible. Very rarely do these result or are treated with thrombectomy, but in some cases they may be amenable to that. Let me see. Fortunately, in cases where patients present and they do not have severe underlying deficits, the the prognosis is actually relatively good. Complete recovery in approximately 80%, and then in a much smaller proportion, death. Of the patients that do have a poor prognosis, coma or being attended on arrival, if they've progressed to the point of intracranial hemorrhage, or if their diagnosis is associated with malignancy, those have a significantly poor prognosis. Okay, so kind of moving into our next case here, we've got a patient that has a young patient, has upper respiratory symptoms, and then very rapidly noticed a developing rash, headache, and neck stiffness, and comes in and is frankly septic. So in this case, extremely high concern for Neisseria meningitis or bacterial meningitis. The mortality here is extremely high in untreated cases. The incidence, fortunately, has gone down significantly due to widely available vaccines to Neisseria and pneumococcus, which are the most common causes. But there's still a relatively large number of patients that do develop bacterial meningitis. Of the patients that have all of the usual findings, headache, fever, neck stiffness, only about 50% of patients have those. And then there's a large proportion of patients that have either one or even none of these symptoms on initial presentation. They may just have, they may have generalized sepsis, or they may have altered mental status, but not have any of the other general symptoms. The risk factors associated with this are known underlying infection, immunosuppression, alcoholism is extremely high, and then the exposure to known pathogen is also very high as well. The most common or some of the most common features: headache, most often worse with movement, fever, vomiting, photophobia are the historical features concerning for this. Altered mental status, papilledema, and then other meningeal signs, as well as purpura and petechia, especially in Neisseria meningitis. Patients that are more likely to have an atypical presentation are going to be the very young and the old, and they may be altered, or they may just have a fever, especially in neonates. And in those, in cases like that, looking for evidence of increased intracranial pressure, papilledema, focal exam, focal neurologic signs is important. And if you do have a high concern for bacterial meningitis, starting especially Neisseria meningitis, initiating antibiotics as soon as possible has a significant impact on mortality. And then certainly recommend against delaying empiric therapy for lumbar puncture and further workup in these cases. Oftentimes, the CSF results in bacterial meningitis will look frankly purulent. Occasionally, it's a little bit less apparent, but the most common results that we would anticipate would be a severely significant leukocyte predominance with PMNs to point us in the direction of bacterial meningitis. There's many different empiric therapies. Often the most important and the most common, I would say, are going to involve a third-generation cephalosporin, such as ceftriaxone or cefotaxime, as well as vancomycin. And then in certain populations, especially the elderly, adding ampicillin as well to treat for listeria is recommended. in bacterial meningitis, using dexamethasone or other steroids has had a significant impact on residual deficits, and can have a very meaningful impact in terms of the patient's recovery, which is why if the suspicion is high enough to treat for bacterial meningitis, then utilizing steroids, specifically dexamethasone, is recommended as well. Okay, got it. Well, ooh, boy. I think I'll stop with those since it's kind of coming up to the hour, and this one's going to be a little while. What I'll do is I can send out these slides so that everybody can continue to look through the slides, but we won't need to continue past the hour, since I know that everybody has a busy day. Did people find that helpful? Was it? I know it's definitely a lot of information to cover.
Yes, because it is one of the more symptom commonly the patient go to emergency department. So I think it's if you have helpful lesson to everybody to review everything, especially in severe situation, we need the time to diagnose exactly for the patient. Okay, very helpful today.
Excellent.
Yes.
Perfect.
Yes.
Well, thank you everyone for your attention, and thank you everyone for our discussion, our question discussion earlier.
Yeah.
I think I really enjoy when we're able to have a slight difference of opinion and good discussion, because I think that it's easier for everyone to learn in those situations. So I'll send out the questions and answers as well as the slides here to cover, since there were a few some slides here at the end that we weren't able to cover. Okay.
Yeah. Yes.
Thank you.
Yeah. Thank you very much. Yeah.
Perfect. And then I'll send out our email for our lectures and questions next week.
Yes. Thank you very much.
Okay. Yes. All right. Everybody have a good day.
Good day too. Okay. Thank you. Good night. Sleep well.
Yes. Yep.
Yeah. Sleep well. Okay.
Tired.
Thank you
Okay.
very much.